chapter is going to discuss the bowel disorder drugs. The previous slide showed the digestive system and is just there as a review of the anatomy and physiology. And we'll talk about the various pathology and then the medications that are associated with those. So obviously what people think of, one of the major things that people think about when they think about disorders of the GI system is diarrhea. And diarrhea basically is just an abnormal passage of stools with increased frequency, fluidity, and weight, or an increase in stool water excretion. With acute diarrhea, it has a sudden onset in a previously healthy person, and it normally will last from 3 days to 2 weeks. It's self-limiting and it resolves without any problems. Chronic diarrhea is diarrhea that lasts for more than 3 to 4 weeks, and it's associated with recurrent passage of diarrheal stools, fever, loss of appetite, nausea, vomiting, weight loss, and chronic weakness. Some of the causes of diarrhea with acute diarrhea is bacterial or viral infections, medications that may have caused the diarrhea, nutritional factors, and possibly protozoa infections. With chronic diarrhea, it may be caused because of tumors, because of diabetes, Addison's disease, hyperthyroidism, irritable bowel syndrome, or HIV/AIDS. The goals of diarrheal therapy is to stop the stool frequencies, to alleviate the abdominal cramps, replenish fluids and electrolytes, and prevent weight loss and nutritional deficits that result from malabsorption due to the increased transit of food through the bowel. Antidiarrheal medications can be divided into 3 different groups: adsorbents, anti-motility drugs, and probiotics. These are also known as intestinal flora modifiers or bacterial replacement drugs. We often think about probiotics as being something that needs to be used after antibiotics use. Looking at the mechanism of action for the antidiarrheals, the adsorbents coat the walls of the gastrointestinal tract, and they bind to whatever the causative bacteria or toxin are, which is then eliminated through the stool. Some examples of these are bismuth subsalicate, which is Pepto-Bismol, activated charcoal, and antilipemic drugs like cholestyramine or cholestyramine. Anti-motility drugs are anticholinergics. So remember, cholinergic drugs are the relax and digest drugs. The anticholinergics mean that they're going to decrease that intestinal tone and decrease the peristalsis in the GI tract. As a result, it's going to slow the movement of the fecal matter through the GI tract. And an example of these are belladonna alkaloids. In addition, opiates also act on the motility of the bowel. They decrease bowel motility and they reduce the pain by relieving the rectal spasms. They also decrease the transit time through the bowel, allowing for more of the water and electrolytes to be absorbed out of the bowel. Some examples of these opiates include paregoric, opium tincture, codeine, and over-the-counter drugs like loperamide and diphenoxylate. With the anticholinergics, They slow peristalsis by reducing the rhythmic contractions and the smooth muscle tone of the GI tract. And that causes a drying effect, and that reduces the gastric secretions. And when they're used in combination with adsorbents, or they may be used in combination with opiates. Probiotics are also known as intestinal flora modifiers or bacterial replacement drugs. These are bacterial cultures of lactobacillus organisms, and they work by supplying missing bacteria to the GI tract, and they suppress the growth of the diarrhea-causing bacteria. And so an example of this would be of Lactobacillus acidophilus, which is one of those ones that we also use with yogurt. Here's your first question of this chapter. The antidiarrheal drug Lomotil contains both diphenyloxylate, a synthetic opiate agonist, and atropine, an anticholinergic. The purpose of the atropine in this combination is to enhance the effects of the diphenyloxylate, B, discourage recreational use of the opiate diphenyloxylate, C, counteract the adverse effects of diphenyloxylate, or D, act as an adsorbent for the bacteria in the bowel. Well, strangely enough, it's B. A small dose of atropine combined with the diphenyloxylate discourages recreational use of this drug because if taken in large doses, a person will experience unpleasant anticholinergic effects like dry mouth, abdominal pain, blurred vision, and tachycardia. So the indications for antidiarrheals are as follows. The adsorbents are used for milder cases of diarrhea. The anticholinergics and opiates are used for more severe cases, and the probiotics are normally used for antibiotic-induced diarrhea. However, probiotics may be used in combination with the others as well because they help to put good bacteria and control the numbers of bad bacteria that may be causing the diarrhea. Next question. A patient is experiencing diarrhea while completing a course of antibiotic therapy. Which of the following agents does the nurse anticipate administering to the patient? L. acidophilus, bismuth subsalicate, diphenyloxate with atropine, or loperamide? And of course, since we've just talked about it, we know that the answer is A, because this is a probiotic and it's often used in the treatment of antibiotic-induced diarrhea. The other agents are usually not used in the treatment of antibiotic-induced diarrhea. In addition, the probiotics may be prescribed prophylactically when somebody's going to be on a little longer course of diarrhea or antibiotics to prevent the diarrhea from occurring. So as with any drug, there's always adverse effects associated with it. With the adsorbents, it can increase bleeding time. It can cause constipation and dark stools, confusion, tinnitus, a metallic taste, and in some people, a blue tongue. With the anticholinergics, there may be urinary retention and impotence, headache, dizziness, confusion, anxiety, drowsiness or confusion, dry skin and flushing, blurred vision, hypotension, and bradycardia. Remember, these are the opposites of cholinergic effects, and so it makes sense that these would be the things that would happen with them. With the opiates, we may have drowsiness, dizziness, and lethargy, nausea, vomiting, and constipation, respiratory depression, hypotension, urinary retention, and flushing. And yes, there's interactions. Adsorbents decrease the absorption of many drugs, including digoxin, quinidine, and hypoglycemic drugs. Adsorbents caused increased bleeding time and bruising when given with anticoagulants, specifically warfarin. Remember what I told you, warfarin is a bad, basically has interactions with almost every drug. Toxic effects of methotrexate are more likely to happen when given with adsorbents. Back to looking at the hematology stuff, a patient who takes Coumadin has been prescribed an adsorbent for diarrhea. It is important for the nurse to assess the patient for bruising because use of Coumadin with adsorbents interferes with the absorption of which vitamin? A, D, E, or K? Well, the answer is D, vitamin K. Oral anticoagulant warfarin is more likely to cause increased bleeding time and bruising when co-administered with adsorbents. This is thought to be because the adsorbents bind to vitamin K, which is needed to make certain clotting factors. Vitamin K is synthesized by the normal bacteria flora in the bowel. So the combination of having had diarrhea to start out with, so you're not synthesizing as much vitamin K, and then to have the adsorption since binding to the vitamin K that is being produced is going to increase the risk of bleeding. So let's think about the nursing implications. We want to obtain a thorough history of bowel patterns, general state of health, and recent history of illness or dietary changes, and assess for allergies. Do not give bismuth subsalicate to children or teenagers with chickenpox or influenza because of the risk of Reye syndrome. Remember, this word subsalicate means that it is a salicate, which is a medication that is related to aspirin. Use adsorbents carefully in older patients and those with decreased bleeding time, clotting disorders, or recent bowel surgery, or if they're confused. Do not administer anticholinergics to patients with a history of narrow angle glaucoma, GI obstruction, myasthenia gravis, paralytic ileus, or toxic megacolon. So before administering belladonna alkaloids, it is important for the nurse to assess the patient for a history of which condition? Anemia, diabetes mellitus, myasthenia gravis, or hypertension? And the answer here is C, because the use of belladonna alkaloid preparations is contraindicated in patients who have shown a hypersensitivity to anticholinergics and in patients with narrow angle glaucoma, GI obstruction, myasthenia gravis, paralytic ileus, and toxic megacolon. Additional nursing implications include teaching the patients to take the medications exactly as prescribed and to be aware of their fluid intake and dietary changes. The nurse should assess the fluid volume status, the I&O, and their mucous membranes before, during, and after initiation of treatment. You want to teach the patients to notify their prescriber immediately if the symptoms persist and monitor for a therapeutic effect. In other words, not so much diarrhea. Which anti-diarrheal does the nurse associated with the development of adverse effects of urinary retention, headache, confusion, dry skin, rash, and blurred vision? Anticholinergics, adsorbents, probiotics, or opiates? Well, the answer here is A, because anticholinergics work by decreasing GI peristalsis through their parasympathetic blocking effects. And so all of the above adverse effects are included when using those medications. So the next common GI disorder that we think about is constipation, and it's an abnormally infrequent and difficult passage of feces through the lower GI tract. It's a symptom, not a disease. And it's a disorder of movement through the colon or rectum. And it can be caused by a variety of diseases or drugs. In severe cases, it may require surgical intervention, but non-surgical treatments are things like dietary with fiber supplementation, behavioral by increasing physical activity, or pharmacologic, as in the medications that we're going to talk about today. Laxatives can be divided into 5 different types. We have bulk forming, we have emollient, meaning stool softeners or lubricant laxatives, hyperosmotic, saline, and stimulant. So let's examine how these medications work. With the bulk forming, it's high fiber. It absorbs water to increase the bulk. It distends the bowel to initiate reflex bowel activity, which basically means as the bowel expands, it reflexively wants to push the stool out. And examples of these are psyllium, which is what we find in Metamucil, and methylcellulose, which is what we find in Citracel. With emollient laxatives, we call these stool softeners and lubricants. They promote more water and fat in the stools. This lubricates the fecal material and the intestinal walls and results in the stool being able to slip out easier. Stool softeners are things like docusate salts like colace and surfact, and lubricants like mineral oil. Hyperosmotic laxatives increase fecal water content, and they result in bowel distension, increased peristalsis, and evacuation. Examples of these are like proethylene glycol, sorbitol, glycerin, lactulose, which is also used to reduce elevated serum ammonium levels. I just wanted to point out here that sorbitol is something that's used in a lot of sugar-free candies and other sweet desserts for people that are going sugar-free. And so one of the side effects of eating too much of these sugar-free candies or sugar-free desserts is that you get diarrhea because the sorbitol causes this hyperosmotic laxative effect. Saline laxatives increase osmotic pressure within the intestinal tract, causing more water to enter the intestines. And this results in bowel distension, increased peristalsis, and evacuation. So examples of these are magnesium hydroxide, which is milk of magnesia, which we talked about earlier when we were talking about the other medications, and magnesium citrate, which is also known as citroma. Stimulant laxatives increase peristalsis via intestinal nerve stimulation. And examples of those are senna, which we see in Senokot, or Biscodol, which is in Dulcolax. I want to point out here when we're talking about the results in bowel distension, in some ways that's a good thing because that bowel being fuller is going to make the person want to go to the bathroom more. But often the bowel distension also has gas involved with it. And so even though it relieves their constipation, often people will get cramping in their bowel because of taking these laxatives. Another group of medications that can be used for constipation are peripherally acting opioid antagonists. So in other words, these are not opioids which cause constipation. These are antagonists. And the treatment of constipation related to opioid use and bowel resection therapy are the main reasons to use these type of meds. They block the entrance of opioid into the bowel, and there is strict regulations for the use. They allow bowel to function normally with continued opioid use. And I don't know if you've seen it or noticed it, but there actually is a medication that's newer than what's here, if I remember right. And it's been advertised recently about somebody who has chronic pain and they have constipation associated with their medications for their chronic pain. This is what they're talking about. So one of these medications is methyl naltrexone, which is Relistor, and the other is alvimopan, which is Entreg. And basically this, because it is peripherally acting, they still get the pain relief that they need from their opioid without blocking the opioid pain response, but it helps with the constipation associated with it. The next couple slides talk about the indications based on the laxative group. You guys can read these things easily on your own, so I'm not going to read each one of the slides for you. Just let you know that they're there, and I'll pick you up when the indication slides are done. A patient is taking lactulose 4 times a day but does not have a history of constipation. In fact, he has had bowel movements every day. What is the probable reason for the lactulose? A. Cleansing the bowel before a procedure. B. Removal of helminths. C. Reduction of high ammonia levels associated with liver failure. Or D. Maintenance to prevent constipation. The answer to this one is C. Lactulose helps reduce blood ammonia levels by converting ammonia to ammonium, which can then be eliminated by the body. There's many adverse effects associated with laxative, and each type has different problems. With bulk-forming laxatives, there's a concern about impaction, fluid overload, electrolyte imbalances, and even esophageal blockage. With emollients, there can be skin rashes, decreased absorption of vitamins, electrolyte imbalances, lipid pneumonias. With hyperosmotic, we can get abdominal bloating, electrolyte imbalances, and rectal irritation. With the saline laxatives, there can be magnesium toxicity with renal insufficiency, cramping, electrolyte imbalances, diarrhea, and increased thirst. With stimulant laxatives, the adverse effects include nutrient malabsorption, skin rashes, gastric irritation, electrolyte imbalances, discolored urine, and rectal irritations. Basically, all laxatives can cause electrolyte imbalances, and many of them affect nutrient absorption. So this is always a concern with anyone who's been taking laxatives for any length of time. And here we are with the nursing implications. The nurse needs to obtain a thorough history of presenting symptoms, elimination patterns, and allergies. When to assess fluid and electrolytes before initiating therapy. Inform the patients not to take a laxative or cathartic if they are experiencing nausea, vomiting, or abdominal pain, as this may be a symptom of a bowel disease that needs to be treated in a different way. A healthy, high-fiber diet and increased fluid intake should be encouraged as an alternative to laxative use. Long-term use of laxatives often results in decreased bowel tone and may lead to dependency. It's amazing how many people have become dependent to their laxatives because they are so used to taking them every day. If they don't take them every day, they don't have a bowel movement. One other thing I wanted to say about laxative dependency is that we often see this in the elderly. The elderly get very fixated on their bowels and their bowel movements. And if they don't have their bowel movement every single day, they are just out of their minds. And so they are the ones that most frequently get this laxative dependency. But remember that the laxative affects absorption of vitamins and really has some long-term problems. So it's something to really watch for in the elderly. So here's your next question. A hospitalized patient is experiencing diarrhea. Which of the following does the nurse identify as adverse side effects of diphenoxylate with atropine therapy? Select all that apply. Increased salivation, abdominal pain, bradycardia, or blurred vision. The answer to this one is B, abdominal pain, and D, blurred vision. When administering diphenoxylate with atropine, the nurse should assess the patient for adverse effects, including dry mouth, abdominal pain, tachycardia, and blurred vision. All laxative tablets should be swallowed whole, not crushed or chewed, especially if they are enterically coated. Patients should take all laxative tablets with 6 to 8 ounces of water because if you think about it, most of them are pulling fluid into the bowel. Patients should take bulk forming laxative as directed by the manufacturer with at least 240 milliliters or 8 ounces of water. Give Biscotal with water because of interactions with milk, antacids, and juices. Inform patients to contact their prescribers if they experience severe abdominal pain, muscle weakness, cramps, or dizziness, which may indicate possible fluid or electrolyte imbalances. A 48-year-old patient has been admitted with abdominal pain and states that she has not had a bowel movement for 4 days. Her abdomen is distended and slightly tender. Which laxative would be appropriate for this patient? Milk of magnesia, a bulk forming laxative, mineral oil, or D, No laxatives should be given at this time. The correct answer is D. These laxatives are contraindicated in the presence of undiagnosed abdominal pain because taking a laxative in case of intestinal obstruction could be very harmful to the patient. No laxative should be given if the patient has undiagnosed abdominal pain. Finally, let's talk about irritable bowel syndrome. When giving medications for irritable bowel syndrome, we want to monitor for therapeutic effect. Chronic intestinal discomfort is characterized by cramps, diarrhea, or constipation. Patients usually cope with the symptoms by avoiding irritating foods or taking over-the-counter laxatives and antidiarrheal drugs. The drugs for irritable bowel syndrome include tegaserod, flubiprostone, and aldosterone. When giving these medications, the nursing implications include performing a general assessment and additional assessment of liver function, as well as assessment for any underlying cardiac disease. You want to follow administration guidelines carefully and assess for therapeutic response.